Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. An article published in Arthritis and Rheumatism in 1977 reads as follows, quote, "An epidemic form of arthritis has been occurring in eastern Connecticut at least since 1972, with the peak incidence of new cases in the summer and early fall. Its identification has been possible because of tight geographic clustering in some areas and because of a characteristic preceding skin lesion in some patients," unquote. After describing the characteristics of the arthritis and plotting the families affected on a map, the article concludes, quote, "Lyme arthritis is thought to be a previously unrecognized clinical entity, the epidemiology of which suggests transmission by an arthropod vector," unquote. The first author of that remarkable paper was none other than Dr. Alan Steere, at the time a postdoctoral fellow in rheumatology at Yale University. For longer than I've been alive, Dr. Steere has continued his pioneering research on Lyme arthritis. In today's episode, we've invited Dr. Alan Steere to discuss the history of Lyme arthritis, starting from his humble beginnings examining families in Lyme, Connecticut with this unusual type of arthritis, to the identification of the borrelia spirochete that causes the disease. We discuss the various manifestations of Lyme disease, including why some patients have more severe disease than others. We'll explore the current challenges in diagnosing Lyme arthritis, antibiotic therapies, post-treatment Lyme disease syndromes, what they are and how to treat them, and how our understanding of Lyme arthritis has shed light on autoimmune arthritis, such as that of rheumatoid arthritis. Dr. Steere is an internationally renowned clinician and researcher in Lyme arthritis with more than 300 publications on the subject. He's the Morse Professor of Medicine at Massachusetts General Hospital, where he is also the Director of Translational Research in Rheumatology. He serves as Professor of Medicine at Harvard Medical School as well. It's really a fascinating discussion with a remarkable clinician and researcher. I really hope you enjoy it as much as I did. Alan, welcome to the show.
Thanks very much, John. It's great to be here.
So tell me, how did you become involved in studying Lyme disease in the 1970s?
Oh, I became involved before there was Lyme disease. I learned of a cluster of children in Lyme, Connecticut, and the children were often diagnosed with juvenile rheumatoid arthritis. I had been at Centers for Disease Control for 2 years before starting rheumatology fellowship, and so I had done outbreak analysis. Well, 4 months into my fellowship, I heard from David Sneidman, who had been someone I'd known at Centers for Disease Control, but he was now working at the Connecticut State Health Department. And he had had calls from 2 mothers about this cluster of children. And he had gone to Lyme, Connecticut, which is pretty close to Yale, where I was in a rheumatology fellowship. And he had done a preliminary investigation, and he thought it was real that this was happening there. He knew I was in a rheumatology fellowship, and he called to ask what I thought. And what I thought was that this was very unusual. So I went to Stephen Malawista, who was the director of the rheumatology division there, and said that I would like to have the opportunity to work on this. And he said, okay. take 6 months and see what you can do. And it's now nearly 50 years later.
Oh my
I'm
goodness.
still working on it. But the children often would meet clinical criteria for juvenile rheumatoid arthritis, but the clustering was really striking. And some of the most striking aspects of it were that on 2 roads, 1 in 10 children had an apparently similar type of arthritis.
Crazy.
And then there were parents who seemed to have a similar type of arthritis as well. But when a family was affected by this, their onset had often been in different years. Suffice it to say that the epidemiologic fingerprint was compatible with an arthropod transmitted illness, something very different
Wow.
in juvenile rheumatoid arthritis. And we called it Lyme arthritis because this was happening in Lyme, Connecticut, and we thought it was something different than had been described before. And indeed, it was.
Wow.
So that was the beginning of my involvement in Lyme disease in 1975.
Wow. So prior to you coming to that community, what was the thought that, is it something in the environment? What were people thinking that was causing this type of unusual juvenile arthritis in these children?
People thought different things, but these 2 mothers thought that there must be some explanation within the environment for what was happening. There were several things that had been noted in the environment. 2 nuclear power plants had been built in the 1960s near Lyme, Connecticut. And
Interesting.
there was concern about that and whether that might have altered the environment in some way. But it had also been noted that they used to never see ticks, and now they were inundated with ticks.
Aha.
But suffice it to say, both the clinical and epidemiologic work started pointing more and more to this being a tick-transmitted illness.
And how did you and your group actually identify the spirochete that was causing Lyme disease?
That was a challenging part of the journey. And it was really a confluence of events. I would say that what we contributed was clinical epidemiologic information that came to really implicate that this was probably a spirochetal infection. And so you can ask, well, why did you think that? We had shown that the skin lesion that often occurred before the onset of arthritis, months before, responded to penicillin and often prevented arthritis.
Huh.
And the pathology, however, was a lymphocytic infiltrate in synovial tissue that looked like what you would see in the chronic inflammatory arthritis. And then the other thing that we had learned from clinical epidemiologic observation was that this was an illness that occurred in stages. It was a complex illness. It often began with a skin lesion at the site of the tick bite, but there could be flu-like symptoms with that. One might then see within several weeks neurologic or cardiac involvement. And arthritis often occurred months later in the illness. And when one put all of that together, a penicillin-sensitive agent that did those things was suggestive of a spirochete. But actually finding it, there were other factors and other people involved, not at Yale, that were tremendously important in how this came about. And one was that Willie Bergdorfer, who was at the Rocky Mountain Laboratory in Hamilton, Montana, became involved with this and had spent his career dissecting ticks and identifying infectious agents in them. And he had noted in one of the ticks that had been sent to him from Long Island, a spirochete.
Wow.
And of the tick-transmitted spirochetes, they're borrelia, essentially. Well, yeah, borrelia. So it had been very difficult to grow borrelia. But Alan Barber had been working on that particular issue and was working on antigenic variation of relapsing fever borrelia, which had been known for over 100 years. but they just worked out a very complicated medium for growing borrelia. So Willy Bergdorfer gave a tick in which he had seen spirochetes to Alan Barber, and Alan Barber was the one who then grew this newly recognized spirochete, now called Borrelia burgdorferi, in his medium and with the contents of this tick. So that was 8 years, though, after
Wow.
the initial observations about the disease. We then showed that, first of all, we could culture this newly recognized spirochete from patients, primarily from the initial skin lesion that occurred at the site of the tick bite, and that patients had an antibody response to it. And so, with that information, we were convinced of the spirochetal etiology of Lyme disease and of Lyme arthritis.
Amazing. So, it sounds like, as you mentioned, based upon your research and epidemiologic data, you suspected it was a spirochete. And then it took several years later to actually identify the spirochete from the skin lesions of patients with the rash, and noting that they made an antibody response, and then sort of tying everything together that it was a tick-borne illness that was causing the arthritis in these patients.
Yes, exactly. You summarized it well.
Very good. That's an incredible story. Why do you think it is that it seems like only a subset of patients actually develop the arthritis, whereas other patients develop Lyme disease and they don't seem to develop arthritis? Do you have any insights into why that may be?
We know there's considerable variation in the Lyme disease spirochete, and I'll call it Borrelia burgdorferi by its Latin name. And we have a number of strains of it in the United States. They have differences in severity, some difference in phenotype. But other species of Lyme disease Borrelia also are found in Europe and in Asia, where the phenotype really is rather different. And in Asia and Europe, Borrelia guerinii, as it's now called, and Borrelia afzelii are not very arthritogenic. It really is the strains in the eastern United States, and particularly in New England, that are particularly arthritogenic. And we have one strain, its name is OSC type A, or RST1. So it's a subtype of Borrelia burgdorferi that is quite virulent and more often associated with severe disease and with what we call post-infectious Lyme arthritis. So, in other words, there are variations in the spirochete and there are host variations as well. But it seems like variations in the spirochete are important in arthritogenicity, and host factors become quite important then in the severity of the arthritis. And I should go ahead and say there really is a marked range. In other words, at the mild end of the spectrum, one may only have mild joint pain or several episodes of mild joint pain, usually that wouldn't even bring a person to see a doctor. Then intermittent attacks of arthritis, but it may be, before we knew the cause of the disease or even treatment of it, we saw people who only had arthritis, let's say, for 2 weeks, and it would go away. But more commonly, it recurred. And then at the far end of the spectrum, it could be persistent and cause destructive disease. So it was that part that really did look like the synovial lesion that one sees with the chronic inflammatory arthritis, which could include what we now call juvenile idiopathic arthritis, but it would also include rheumatoid arthritis or psoriatic arthritis. Having said that, we now know some particularly microscopic details that one sees with post-infectious Lyme arthritis that one does not see with the other chronic inflammatory arthritis. So there are some specificities, but still, in general, it's a lesion that is a lot like the chronic inflammatory arthritis. But there's that range in what
Fascinating.
happens.
Fascinating. And as you mentioned, it's both probably related to host factors, but also to related to the subtype of the spirochete that is infected. And what exactly is happening inside the joint? Does the spirochete get into the joint and invade the joint, or do you have sort of pieces of spirochetes that are just mounting an immune response in the joint?
Yes, the spirochete does get to the joint. And so maybe I should say something about its journey.
Mm.
It usually starts out in the skin,
Yep.
and there's an expanding skin lesion that in which the spirochete is expanding in the skin. But strains, particularly in the northeastern United States, usually disseminate. And so they actually go to many sites, or there's the potential for them to go to many sites. But one of them it's particularly tropic for connective tissues in the joint.
Mm.
So this would include synovial tissue, but it's not just synovial tissue. It would also include tendons.
Mm.
And yes, the spirochete gets there. And then there is a host immune response.
Fascinating. And that the host immune response, I guess, is what you're looking for in diagnosing Lyme arthritis. What are some of the challenges and some of the mistakes that people do when trying to diagnose patients with Lyme?
There's a complex immune response that occurs, but the antibody response is particularly important in control of the infection. So people usually mount very high antibody responses to the organism over time. But it is difficult to actually culture the spirochete from any site other than in the initial skin lesion. It's still been done successfully sometimes earlier on from cerebrospinal fluid in the first weeks. But by the time it gets to the joint, it's in specific niches in tissue, and we have never cultured it successfully.
Wow.
There have been a few reports of doing that, but that was not possible to really grow the organism and passage it. So, at any rate, in other words, indirect methods are what's necessary in terms of seeking laboratory support for this diagnosis. Antibody testing is indirect. As I said, one mounts a very high antibody response, and that's our best test at this point for supporting the diagnosis of Lyme arthritis. With successful treatment, the antibody response declines, but it usually levels off at a low positive range, and it remains positive indefinitely. I always tell patients that's actually good because you have been vaccinated by nature. We do not see, or we've rarely seen, if ever, reinfection in a patient who has that type of expanded antibody response that one gets with Lyme arthritis. So, at any rate, the problem is, though, it does remain problem. I mean, it remains positive indefinitely. So that if a person develops something else, another type of arthritis, another neurologic disease, something that's not so clear what's causing it, the antibody test for Lyme disease would still be positive. One of the current problems of serologic testing, which is antibody testing, is that from a commercial laboratory, one does not get a quantitative value about the amount of antibody. One gets a report of what spirochetal proteins the antibodies are directed against,
Right.
or in the new modified two-tiered testing, it's simply one gets a report of positive or negative. But in somebody who's had Lyme arthritis in the past, that test is going to remain positive indefinitely. So we use a quantitative type of test to help us. When a person is actively infected, the amount of antibody is usually very high and then becomes low-level positive once the infection has been treated adequately. But that's not information you can really get from a commercial laboratory. And the reason is that the CDC has not endorsed that type of work because to report an accurate curve, it has taken testing the sequential sera on the same plate, which means that previous sera have to be frozen.
Uh,
And, a commercial laboratory is not going to be in a
yeah,
position to do that.
got it. So that's something that you guys are doing in your lab these days?
We do it. We've done
Got
it
it.
all along, but it's because we're a research
Yeah,
laboratory and we're saving samples.
yeah.
But I do think that's a challenge that can probably be worked out and would be an advance in serologic testing and helping decisions about whether antibiotic treatment has been adequate or not.
Interesting. So in the commercial lab space, you hinted at the two-tier testing. I believe you do first an ELISA,
Yes.
where I think it gives you either maybe a titer or positive or
Well,
negative.
yeah. The way it's been recommended to be set up is that you get either a positive, equivocal, or negative response. And if it's equivocal or positive, you should go on and do the next test, which is a Western blot, usually, in which there are 10 spirochetal proteins, and one learns if a patient has reactivity with them. And patients with Lyme arthritis usually have reactivity with 9 or 10 of them.
Mm,
A lot.
got it. So that helps you so you would expect somebody with Lyme arthritis to have a positive ELISA and a positive Western blot with many positive bands in
Yes,
the IgG.
that's right.
Got it. And because if it's IgM, negative IgG, that doesn't typically go with Lyme arthritis?
Well, an IgM response can persist in Lyme disease.
Okay.
So it doesn't tell you with certainty that it's early infection or even that it's active infection. It doesn't tell you with certainty.
Got it.
Again, we find quantitating the amount helpful, but it's not a test that's commercially available. But you're right, Lyme arthritis usually has a particular clinical appearance, most commonly that a knee is swollen, quite swollen, or both knees. There can be other joints, but it's particularly knees. And accompanied by this very expanded antibody response to the spirochete. Usually, that's what one sees. That would be the common picture. One can usually treat that successfully with doxycycline, but not always.
So just to clarify, going back on the commercial testing, I understand the limitations that you mentioned, but do you think commercial testing will miss any patient with Lyme arthritis?
It must be quite rare.
Okay.
At least the state of our knowledge now is that patients with Borrelia burgdorferi, Lyme arthritis, have very high antibody responses to the spirochete. If you have a patient who's not able to make an antibody response, but most people can make some antibody response. Of course, we now certainly have immunosuppressed patients who are immunosuppressed for some other reason, who have a tick bite, get Lyme arthritis on top of
Mm.
their other disease, which is causing immunosuppression. And that patient may not handle the infection quite as well or as easily, but usually there's still an antibody response, and usually they still respond to antibiotic therapy.
Okay. So it sounds like commercial labs are still good at detecting, but you won't get those nuances, whether it's, somebody with like flagrant Lyme arthritis or to document that the antibody quantity has decreased as you treat patients over time.
That's right. That's right. That's the information that you will not get. And what's more, the Western blot is not a quantitative test, and it
Ah,
changes very little or very slowly
ah,
after treatment. So one's not expecting these tests to come back down to being negative. And I think that's a common mistake. One's either worried that somebody's still infected because of that, but that's not a test that can tell you that with certainty,
that's
or
great.
that some other condition that they develop later gets attributed to Lyme disease because those tests are positive. So one's really dependent on that the clinical picture is one that we associate with active infection, and the clinical picture can be complicated.
Yeah, I mean, I think that's one of the challenges. We get referred patients to our clinics in patients with joint pain or joint swelling. And oftentimes, one of the sort of reflex tests that gets ordered is Lyme testing for anybody with joint pain. So, which do you think are the types of patients that should get tested for Lyme disease when you suspect Lyme arthritis? Is it, a patient with joint pain, or is it a specific patient with, swollen joints in the knees?
It's not an easy question to answer. I
Hmm.
mean, certainly there's classic Lyme arthritis where a single knee is quite swollen. And the patient presents with that, and there's really no preceding history to help you understand what's happened. And so monoarthritis of a knee has a rather large differential diagnosis, and their serologic testing is definitely something that will help you say, all right, this is Lyme arthritis. But what one is looking for is an IgG antibody response, usually to most, if not all, of the spirochetal proteins that are tested for. And maybe I should say here as well, the modified two-tiered testing is just two ELISAs, and they give you that either there's a positive IgM or a positive IgG response or both. And if you get an IgG response in that test, you really do not know that you have an expanded response against many proteins. So the purpose of the modified two-tier test is it is more sensitive in early disease, in the patients with erythema migrans, in the first days of illness. But for someone with arthritis, I think one does much better with what's called a standard two-tier testing, which means ELISA and then Western blot, and at least knowing that you have an expanded antibody response. And of course, I also like knowing, because we can get the information, it's one more data point, that the value, the amount of antibody is also quite high. That's typical standard Lyme arthritis, but yes, it's not always as easy as that. And, I mentioned when I first talked that Lyme disease can first cause some joint pain. So early on, one may have that, often with some other symptoms too, but one may have joint pain and without frank arthritis yet. And some patients never develop frank arthritis, but then the joint pain goes away, usually. So I wouldn't say that I'd never do serologic testing, but in a patient who really, let's say, meets criteria for fibromyalgia and has diffuse pain, that's really not a Lyme disease syndrome. That morphs into that we can see post-infectious pain and fatigue syndromes following Lyme disease. Lyme disease is not easy.
Yeah, it sounds even after 50 years, Alan, it doesn't seem to be so easy. What about the role of PCR from the joint fluid? Is that helpful in diagnosing Lyme arthritis?
That test is often positive prior to antibiotic therapy. So if you are seeing someone who has not yet received antibiotic therapy and has quite a swollen knee, joint fluid will generally also be positive for B. burgdorferi DNA. But if the patient has received antibiotic therapy, and it doesn't take very much antibiotic therapy, in other words, not for very long, that test generally becomes negative.
Oh,
And it
interesting.
stays negative. And it doesn't tell you with certainty that all spirochetes have been killed. It does not. So
Amazing.
it's roughly 70% of patients, in our hands at any rate, who would have a positive PCR test before antibiotic therapy, a positive PCR test on joint fluid. But then once the patient gets treated, generally that test becomes negative. And it doesn't tell you that they've had spirochetal eradication.
Got it. So let's talk a little bit about treatment. You sort of hinted at, doxycycline as the standard of treatment for somebody with Lyme arthritis. What should the length of the antibiotics be, and what percentage of patients do you think get completely better after that first course of oral antibiotics?
It varies by the strain they're infected with, and we usually don't know the strain they're infected with. But I'll even say the majority can be treated with 1 month of oral doxycycline. In fact, the fellows used to love to tease me, saying the only thing you need to know about Lyme arthritis, swollen knee, 10 bands on the Western blot, and a month of doxycycline. The easiest rheumatic disease we ever see
Uh-huh.
to deal with. Well, maybe for the majority that's true, but it's not always that easy at all. So there's really marked variation in what one's going to see at 1 month of treatment. And there will be the person who's well at that point. But there's also will be the person who maybe it's 50% better, but the knee's still fairly swollen. And then there'll also be the person whom it really didn't change at all
Mm.
with 1 month of doxycycline. What's one to think then? Do they have another type of arthritis? Is it Lyme arthritis but not responding in the way we usually expect? And that's who gets referred to me.
Got it.
If there's an incomplete response, but let's say they're 50, 75% better, we're inclined to go ahead and treat with another month of oral doxycycline. Is that absolutely necessary? Maybe not, but we generally do that. On the other hand, if there's been minimal response to 1 month of oral doxycycline, we generally go on to intravenous antibiotic therapy, but that is a big step up.
Mm-hmm.
And rheumatologists are often not used to giving intravenous antibiotics.
Right.
And maybe the ID people don't want to do it either. I don't know. I just made that up. But sometimes we go ahead and give a second month of doxycycline. Usually it does not work.
Mm.
In other words, in someone who had no response with 4 weeks, they usually don't have a complete response by 8 weeks. And at any rate, we will generally give intravenous antibiotics at that point, and most of those people do improve. But there's a subgroup in whom the arthritis changes at that point, and rather than the joint being so swollen with fluid, it becomes more synovial hypertrophy, and it can become massive synovial hypertrophy. And we're treating that like one treats the other chronic inflammatory arthritides. So with DMARDs, in other words, so methotrexate, the TNF inhibitor, and generally successfully.
So do you think those are people that had Lyme arthritis and then Lyme sort of triggered this immune response, this autoimmune response, or is it patients that maybe never had Lyme arthritis who incidentally had positive bands on the Western blot caused by,
Yeah.
or is it a mix?
Like my answer to everything, isn't it, is it depends. I do think there can be specific aspects of Lyme arthritis and post-infectious Lyme arthritis that differentiate it from any other type of arthritis. And in that group of patients, a very intense, excessive immune response, I'll just explain it that way rather than all the particulars, develops during the infection, and it does not turn off appropriately. The regulatory arm doesn't work appropriately. And autoimmunity, the development of autoimmunity and cytotoxic phenomena in the joint is a part of that. And then you get a synovial lesion that looks like much like the other chronic inflammatory arthritides. Lyme arthritis, post-infectious Lyme arthritis, has more in the way of vascular damage and sometimes obliterative microvascular lesions that one does not see in the other chronic inflammatory arthritides. So it generally responds well, though, to DMARD therapy. But we have also had patients, and particularly with early Lyme disease, who get treated with antibiotic therapy successfully and 2, 3, 4 months later develop a picture that looks like rheumatoid arthritis or psoriatic arthritis. And so there, I think it may be the adjuvant effect of having had an infection in someone with latent autoimmunity that trips it over into being clinically expressed. So those patients also need to be treated with DMARD therapy. So in some ways, our treatment isn't so different, even though we think there are different mechanisms involved there.
Got it. And at the initial setting, when you're giving people antibiotic treatment, do you ever think about giving anti-inflammatory treatment or something to maybe dampen that immune response and prevent the development of that post-infectious arthritis, like NSAIDs, or even thinking about steroids?
Yeah, we think about it, and some people have even recommended it. The role of steroids, intra-articular steroids in Lyme arthritis, is somewhat controversial and not really clear yet. Some people think it makes the infection more severe. We know that steroids are permissive to the spirochete. You get more of them. The macrophages leave the joint. So you don't have as much inflammation, but the spirochete is saying, great. So that's one view of it. But there are also reports of thinking that it's beneficial and that you can even prevent post-infectious Lyme arthritis if you treat with steroids as well as antibiotic therapy in the early period. I mean, we haven't done that very much, but that's not our experience with it. So we're still in the mindset of when we think the patient is infected, with treating them simply with antibiotic therapy. And one of the problems of going ahead with anti-inflammatory therapy, well, I mean, one could treat with an NSAID, but let's say with methotrexate or steroids at that same time, is that we don't have an easy way of identifying who is going to develop a post-infectious course.
Right.
And since the role of treating with drugs like methotrexate or steroids in the infectious phase has not really been studied. It's not been studied systematically. It's harder to recommend that maybe that's a good thing to do.
So it sounds like for treatment, you basically do oral doxycycline. If patients who may have had, some response, you're thinking about a second course of oral antibiotics, or if they don't respond, you do maybe a month of ceftriaxone. And after that, do you ever consider more antibiotics, or is that, if you're thinking, you finish a month of IV ceftriaxone, whatever spirochete may have been there is no longer there, and you switch roles to giving more of the DMARD approach?
If an antibody response after all of that just stays very high indefinitely, it worries me that somebody's still infected. And we have had a few patients, but it's a handful. Maybe it's not even the hand that's full, in whom we have treated with a second month of ceftriaxone. But in other words, rarely have we done that, and we generally do not think that it is necessary.
Okay, and do you provide, in those patients who maybe still have a swollen knee, do you provide corticosteroid injections at that time, after finishing the antibiotics course?
You could, but I think of it, if that works, it's usually a patient in whom the arthritis would resolve anyway. In other words, there's a sort of patient who you treat with intravenous ceftriaxone, and let's say they're 70% better. And usually, by the way, one does not start to see improvement until the third or fourth week of antibiotic therapy. And if they've had some improvement with it, let's say marked improvement even, 70%, but there's still some joint swelling, usually that will resolve on its own. Now, you can give a corticosteroid injection too with that. But if it's the person who really is developing marked synovial hypertrophy, and one can find that out from MRI scanning, from ultrasound examination, one of those ways. Our experience is that one injection of intra-articular steroids have not worked, and that you really do need to use DMARDs.
Hmm.
Methotrexate, it really is like rheumatoid arthritis in that way, where we think of in rheumatoid arthritis, giving steroids is usually more a way of getting a person over a difficult period, not a long-term treatment and certainly not curative for it. And that methotrexate, or now the biologic DMARDs as well, are much more likely to give one a response that is lasting.
Got it. And in patients with rheumatoid arthritis, for instance, we think about immunosuppression that's probably going to be lifelong. What about the length of treatment in some of these patients? Is that for months? Is it for years? Or does it really depend on each patient?
This is not a type of arthritis that goes on indefinitely. And
Mm.
by the way, even before we knew about antibiotic treatment, this was not a type of arthritis that went on indefinitely. Now, it could take, I'm talking about untreated, 5, 6 years to resolve at the
Okay.
far end of the spectrum, and it could do damage during that period of time. But it resolved. Why is that? I think the immune response eventually wins out. That going into a person is a dead end for the spirochete. And it's an intense immune response generally that it generates, and eventually that wins out, even when the spirochete is in a protected niche, let's say in tendons. Now, with DMARD therapy for post-infectious Lyme arthritis, generally we're not giving it for longer than 6 to 12 months.
Okay.
Sometimes there are people that are harder to treat. And so I have on occasion, again, it's like in a handful, treated for as long as 4 or 5 years, but that's very unusual for this disease. So you can ask, I realize you haven't, but you could ask, why is that? Why does this not last indefinitely? I think it shows the importance of the spirochete in generating this kind of excessive dysregulated immune response. And with spirochetal killing, with antibiotic therapy and the host immune response, that the immune system reaches homeostasis again.
Mm.
This does not go on. An adaptive immune response generally does not go on indefinitely without having the antigens that are pushing it. And even when there's autoimmunity, that the innate immune signals, which may come from some spirochetal remnants, are just not there any longer.
That's definitely reassuring.
Yes, so is that telling us something about rheumatoid arthritis?
Huh.
Maybe.
That's interesting that you think that the antigen would still be, whatever antigen may still be present.
Or antigens.
Uh-huh.
Yeah. Well, the field of rheumatology, but we have also been quite interested in working in parallel with studies of rheumatoid arthritis, with studies of post-infectious and infectious Lyme arthritis. And we have been very interested in what the people at University of Colorado, Michael Hollers, call the mucosal origins hypothesis of rheumatoid arthritis, that the disease is actually beginning like what's happening in the mouth, in the lung, in the large bowel, in the gut. And so I'll speak about the gut, that the hypothesis, the current hypothesis, is that there are certain microorganisms that can trigger an immune response that may be important in controlling that organism in the mucosa, but when it is translated or translocated to the joint, becomes, well, a disadvantageous, even destructive immune response. But yes, one can wonder if the mucosal response continues to push that response that's happening in joints. It's completely a hypothesis at this point. That's not known to be the case, but those are going to be important things to learn.
So interesting that you've, by studying this infection, you're able to elucidate sort of mechanisms of some of our other, chronic, more autoimmune diseases.
Well, at least we can think about them and study them. But I think it's true. The message of Lyme disease is that an infectious agent, in this case, it's a tick-transmitted spirochetal infectious agent can trigger, a disadvantageous excessive immune response in which one loses regulatory control of it. And within that milieu, the consequences include autoimmunity and cytotoxic phenomena.
Yeah.
And by the way, it is only certain strains of the spirochete that seem capable of doing that. So what is it about those certain strains? I mean, we know that, I'll use the slang expression, they're souped up. They're just particularly more lipoproteins, and they just generate a really marked response, but there are also host factors that allow that to happen.
Yeah, fascinating. And Alan, after treating patients for Lyme arthritis, for many of our patients, the arthritis actually resolves, but they continue having symptoms, either joint pain or symptoms of fatigue. Can you talk a little bit more about your thoughts about, that post-treatment Lyme syndrome?
A very difficult problem. I mean, it's been known for years that certain infections may trigger post-infectious pain, neurocognitive fatigue syndromes. And it is not well understood in any of them why that happens. This problem has really been brought to the fore recently by COVID.
Yep.
Where, the estimates are that as high as 20, 30% of people may have some post-infectious symptomatology. And then in any of these, but we're going to talk about post-infectious Lyme disease syndrome at this time, there's a great range all the way from, let's say, months of fatigue, but it does improve, to the person who is just absolutely disabled thereafter by what happens, and it remains that way. And in those people, it's a syndrome that looks somewhat like fibromyalgia, which was something rheumatologists would be quite familiar with. It is not understood at this point how that happens, and it is difficult to treat. The idea that one can treat indefinitely with antibiotic therapy and that helps because they're chronically infected, that has not been shown to be the case in these patients. And so we're left with the sorts of supportive things that are done or that we try to do for fibromyalgia that we would do for post-treatment Lyme disease syndrome as well. So, some people are helped by certain medications. Amitriptyline is one that's sometimes used. Maybe as many as half of people really don't get any help from that type of approach, but may be helped by more of a physical program. I'll call it physical therapy, but in which one tries, in essence, to do more. And many people improve over time. There can be support groups that help in this process if it is with a health professional who is really adept at working with this kind of problem. But it's a great problem, and one that is going to require considerably more work to try to understand, not just in Lyme disease, but overall.
Yeah, and I think at least my understanding is that for those syndromes, fibromyalgia, chronic fatigue, the NIH has really taken this seriously with investments and money to try to help to sort this out.
Oh, that is very true. Very true. And it's also, they have supported a great deal such studies for post-treatment Lyme disease syndrome.
Fantastic. So talk a little bit about how Lyme disease can be prevented, if at all.
Oh, I think it can, because it's a tick-transmitted illness. So there are various personal protective measures that one can take. That's not so easy to do, but one I'll mention is that so-called insect repellents, like off, do deter ticks. So if you're going for a walk in the woods, using, an insect repellent containing DEET, off happens to be one of them, can be beneficial. But it's a tiny tick, and personal protective measures haven't really prevented the problem. So there's great hope that vaccination will become available again, maybe as early as 2026. And that will be an important personal decision, but protective measure.
Amazing. And how do you expect climate change to affect the epidemiology of Lyme disease? You've been mentioning about the ticks within the Northeast, which is where we both live. Do you expect climate change to impact sort of who's at risk of developing Lyme in the future?
Well, one thing that we see that it's doing is it is increasing the period in which ticks are active. When we first started, it's the nymphal stage of the tick that usually transmits the infection. And in the Lyme, Connecticut area when we started, was usually active by about mid-May through the end of July. But that was it. Now that period becomes earlier in the spring, at least several weeks earlier,
Oh, wow.
and probably also extends several weeks later in the fall. So that's one aspect of what's happened because of climate change. But we now know of the ticks spreading as far north as Quebec City,
Wow.
maybe even farther in Canada. So the range is spreading out from what it was before.
More work for you, Alan.
Well, I'm not really working on that particular part of it. So, John, I'm leaving that to you.
Alan, you mentioned before you've been working on this field for 50 years. What still keeps you motivated and engaged in this whole research of Lyme arthritis?
It's a challenging illness, and there's lots left to work on with it. And I do remain engaged with it. And, for the past 20 years, I've really been quite interested in working on the science of it, how one develops a post-treatment Lyme arthritis that is really like other chronic inflammatory arthritides, and working on other, rheumatoid arthritis, namely, along with that. So it's all quite a puzzle. And I continue to be engaged by working on it.
I love it. Alan, you've been really an inspiration to a lot of us. All the advances that you've done in the field of Lyme disease and Lyme arthritis in specific, everything we've all learned and all the, thousands or millions of patients that have benefited from your findings. I think, we all need to acknowledge and thank you for that. And thank you for continuing to keep going and doing what you do every day.
Well, you're very kind. Thank you very much. And I should say this, it's possible for me to keep going because of the younger generation, people like yourself who bring lots of skills, knowledge that I do not have. So we work on it together.
Awesome. Thank you so much, Alan.
Thank you.
What an opportunity to learn about the history of Lyme disease, both about the knowledge we've gained over the past 40 years, as well as all the questions that remain unanswered. It reminded me of the book Ignorance by Stuart Firestein. In it, he describes this scene, quote, George Bernard Shaw, in a toast at a dinner feting Albert Einstein, proclaimed, quote, science is always wrong. It never solves a problem without creating 10 more, unquote. He then states, quote, science, then, is not like the onion in the often used analogy of stripping away layer after layer to get at some core, central, fundamental truth. Rather, it's like the magic well. No matter how many buckets of water you remove, there's always another one to be had. Or even better, it's like the widening ripples on the surface of a pond, the ever larger circumference in touch with more and more of what's outside the circle, the unknown, unquote. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep expanding those ripples. And of course, stay healthy.